Good evening, everyone, and welcome to tonight's MBS item number update. My name is Evelina Kozok. I'm part of the practice support team in Central and Eastern Sydney PHN. With us today, we have Berta, who is the manager of CPD in our office. Also, Riva is joining us today from our mental health team. And of course, Wendy O'Meara, who you already know from the first webinar. So, CESPEN is sponsoring the infection control sessions just for your practice. Allied health provider, GP practitioner, you can book it through coronavirus email. It is 50-minute Zoom session, one-on-one with your practice. So it will be specific to your practice. And what is it about? It's all about how to work today, how to work with the COVID patients, how to work with the patient who may be infectious, how to protect yourself with your PPE, how to clean your practice, how to protect your staff in the front. What can we do to maximize our safety in the practice without minimizing our seeing patients in the same time? The sessions are done with Margaret Jennings. She's microbiologist from Melbourne and leading infection control educator. So just if you feel that it will be good for your practice, send us an email. It's 50 minutes basically, and it can be one person attending from the practice and then share the video with the rest of the GPs. Sometimes we have like all the GPs and nurses attending the same session. So now I would like to introduce and welcome our speaker, Wendy O'Meara. Wendy worked in the general practice sector for many, many years as a senior operations manager in the large regional general practice in Victoria. She will share her excellent knowledge of Medicare guidelines and Medicare interpretation with us tonight, so we can improve processes and maximize our outcomes in general practice allied health professionals. Welcome, Wendy.
Thank you so much, Evelina, and everybody. Welcome to tonight's presentation. I'm really excited to be presenting tonight's topic on mental health for residents of aged care facility, particularly for those who have been impacted by COVID-19. This is the second webinar I've presented, as you know, and I'm very grateful to you all for joining us tonight. So we are on a limited time span, so we'll just keep moving. So for tonight, the objectives at the end of tonight's session, I would hope that you'll be able to recall the impact that COVID-19 has had on the mental health of the residents within our residential aged care facilities. Also to describe the Better Access Initiative, which is the basis for this funding, and to define the eligibility criteria that's available along with the referral process for your residents. And of course, to outline the new temporary MBS item numbers for GPs and then the allied health mental health workers such as psychologists, OTs and social workers. And of course, to be able to locate the relevant fact sheets. So just a bit of a snapshot for where we are at the moment. This is a resource or a snapshot of where we are as far as deaths in and cases within residential aged care facilities as of the 6th of November. As you can see, when we look in New South Wales, there's currently have 281 cases active in your facilities, with quite a few deaths. Deaths would be, so as of the 6th of November, there have been 819 deaths in aged care facilities in Australia. Unfortunately, Victoria is leading the way with 717. New South Wales has to date recorded 93 deaths, and obviously the difference in those numbers is the other states and territories. And at the moment, New South Wales has 484 cases of COVID-19, so it's still pretty scary out there. So some context, so put into perspective where we're coming from. What is this all about tonight? This new initiative is a direct result of the Royal Commission inquiry into the quality and safety of aged care within Australia, which ran for over 18 months. Obviously, it was instigated in June 2018 or July 2018 by the Governor-General, and post that COVID-19 hit. So that was able to be encompassed in the program, and there were reports tabled to the government on recommendations to reform the quality of care that's being received in our aged care facilities. And of that report, 148 wide-ranging recommendations were recommended for the fundamental reform of the aged care system. So there's lots of work to be done. Obviously, I'm not going to go through the whole 148 tonight, but there are 3 that are most relevant to tonight's presentation that I'd like to touch on. So the first one, as I said, the first one is recommendation 3, which is the Australian government should urgently create MBS item numbers to increase the provision for allied health, mental health services to people in aged care, particularly during the pandemic. This is also important. Any barriers, whether real or perceived, to allied health being able to enter residential aged care facilities should be removed unless there's a genuine public health on genuine public health grounds. So obviously being able to get providers back into these homes is so important, and barriers being removed will allow that to happen. So that's part of the recommendation. Recommendation 61, which is the one we're going to focus most on tonight, is to create a schedule of new item numbers, which enable allied health practitioners to provide services to residents of aged care facilities, both in allied health, so the physical therapies, but more importantly for tonight's presentation, on the mental health component of it. And that includes psychologists, occupational therapists, and social workers, of course, along with registered GPs. And this should cease on the 30th of June 2024 when the aged care health funding arrangements are established. So what that actually means is, as of 2024, the focus on the funding for aged care facilities will move towards a more patient-focused care. So it will be ensuring that the assessments performed on the residents actually aim at restoring their physical and mental health to the highest possible level, and ensuring funding includes an amount applicable for allied health to ensure that those services are provided. So I think that's really fantastic. Okay, so mental health, what have we got to offer? At the moment, COVID-19, without a doubt, has been the greatest challenge the aged care sector has ever faced. We've seen it ourselves, GPs having to attend their facilities. Just in the news, it's been horrendous. It's been a significant, or had a significant impact on the lives of the residents living in these facilities, both physically and mentally, with deconditioning particularly obvious in their physical conditions, but the mental effect has been phenomenal. A huge increase in depression and anxiety related to this. And let's not forget, there is also that correlation between physical and mental health. If you're physically well, you're mentally well, and vice versa. So it's important that we don't forget these two do go hand in hand. So when we look at the impacts of residents in the facilities, obviously the biggest one has been the isolation from their family, other residents, their care workers, and of course other providers. So GPs and allied health have not been able to go into the facilities. So there's been that restriction of service provision. And the fear of contracting and dying from COVID-19 has been very real for these people, or these residents, because of their age and their vulnerabilities, I guess. Quarantined in rooms for extended periods of time during lockdown. So sometimes, I think the very first case in New South Wales, the one I read the research on it, there was actually 6 weeks of isolation where the residents were actually quarantined to their room while the infection control was I guess the main focus. Obviously, there are high threat of illness due to comorbidities that they have in the elderly, and the loss of social support. So the family support, taking them out, just the social interaction within the facility. So the lack of dining room attendances and group things that they were doing. So the impact has been so significant on them, and it's ongoing. I have just included a little slide on dementia because this does come into play a little bit. So at the moment, these are statistics from AIHW of the number of residents that are living in aged care facilities who have dementia. And as you can see, the age group between 85 to 89 with dementia, there's around 30,000, over 30,000 residents in that age group alone. So it's pretty scary. And again, this is another section, particularly on new entrants to aged care facilities. So this was a little bit older. This was done in 2018, but it shows again the age group we're looking at mostly is the 75 to 95-year-olds as far as dementia goes. But what is important about that is this slide here, which shows the correlation between dementia and other comorbidities. So depression and mood disorders, as you can see, there's with people with dementia have up to 45–50% comorbidities, so different with depression as well. So it's pretty scary, and this is what the focus has got to be on for us. It's about how we get these residents the care that they need to prevent this illness or these mental health conditions from escalating. So the data tells us basically that 49% of residential aged care residents were diagnosed with depression in the 2018-2019 period, compared with only 7% of males and 12% of females in the community. And as working in general practice, it seems our days are full of patients with mental health. So it's really quite alarming to see that the huge amount of residents that have actually had a diagnosis of some kind of depression. 53% of residents were diagnosed with dementia, and that's up to 240,000 residents currently receiving care in Australia. And of course, these numbers are expected to escalate as a direct result of the impact of COVID-19. And there is wording, or they're saying now, that the next pandemic is going to be the depression or the deconditioning pandemic, how we get ourselves back, or our residents back into some kind of condition where they're able to function normally. So mental health conditions, I think to understand that we need to know there's two types. So there's a transient, a one-off episode. There's also the chronic long-term that occur throughout our lives. And mental health, particularly in people over the age of 65, is often dismissed as normal symptoms of aging. So this program is about getting recognition of their conditions and actually getting them the treatment that they need. And it's very common to experience depression or anxiety when a patient or a person in the community transitions into an aged care facility for ongoing care. So the most common mental health disorders, and there's quite a few of them, so I will just quickly bring them up. Obviously, the most common: dementia, delirium, depression, panic disorder, anxiety. We've seen all of them, including eating disorder, particularly in the aged care facilities, when they move from looking after themselves and caring for themselves and cooking for themselves to having someone else prepare meals for them. Obviously, eating disorders can occur there. So just to give you an idea of what these are the services that, or the conditions that are eligible for this treatment, with the exception of the first two, and I will touch base on that right now. So with the Better Access program, the exclusion to the provision of these services for residents with dementia, delirium, tobacco use disorder, and mental retardation. And they're not recognised for the purpose of this initiative. However, they can be recognised if they coexist with another condition. So if your resident has dementia but also has depression or anxiety, then they are more than eligible for this new incentive. The reason it's been excluded is purely because, in recognition that these disorders require specialist treatment. They require the input of psychiatrists and geriatricians and other service providers, which by delaying that process or delaying that referral can actually, the issue be a priority. So by giving them or referring them to services that are not necessarily going to be helpful to them, it's delaying the outcome for them. So that is the particular reason that they have been excluded solely on their own. But as I said, if the residents do have a co-condition, so something like depression, they're certainly eligible for this. The other thing I just wanted to very quickly talk about was the benefits of exercise on mental health. If you were present for the first presentation that I presented, you could see the benefits of exercise were well documented there. But light to moderate doses and intensities of exercise has a significant impact on the mental health of people. When you have a loss of socialisation and general mental health problems, along with decreased exercise, it has had a substantial negative effect on the elderly population. And although lockdowns can be temporary, these effects are likely to be long-lasting and could pose significant risk to the quality of life of these people. So please don't forget about exercise when we're looking at the big picture for our residents. Okay, so the mental health program, what is available at the moment? Just a brief overview of the Better Access Initiative, because this is the basis for this funding. The Better Access Initiative was introduced in 2006, so it's been around for 15 years, with the goal to improve the treatment and management of mental health disorders for anyone diagnosed with a mental health condition. They must be referred under a mental health plan, and in 2017 it was expanded to include telehealth for rural and remote areas to allow people with less access more access. What it allows was 10 individual and 10 group sessions in one calendar year for anyone who has a mental health plan. And the service providers can either be clinical psychologists who use psychological therapies or registered psychologists and appropriately trained GPs, OTs and social workers in focused psychological strategies. And now it's been expanded to include residents of aged care facilities who have had their mental health impacted by COVID-19. So it's about time. It's fantastic news. What's scary, I guess, is the fact that it was introduced nearly 12 months ago, and there's still a lot of us who don't know about it. So it never ceases to amaze me how much feedback I get from these presentations of that GPs that did not even know about the program, and we're 12 months into an 18-month program. So that's pretty scary. So thank you all for coming tonight and learning about it and getting the word out there. So on the 10th of December 2020 to the 30th of June 2022, the Better Access program has been expanded to include aged care residents impacted by COVID-19. The residents must be diagnosed with a mental health disorder, and we've covered this, but basically what we're looking at, I guess, for COVID-19 is the anxiety and depression aspect. It now allows these residents to access up to 20 individual psychological services per calendar year. But so that's January to December. So if anyone's thinking like I am, it's now November and it's nearly December, and we're going to be using a calendar year, the calendar year is nearly finished. Let's get those referrals happening. Let's get these people referred to services to help them and get as many services we can in between now and the end of the year. The flag fall has been extended, so there has been a flag fall created, which I'll touch on shortly with the actual item numbers, to attract service providers. So it's been extended to cover all of these services. So anyone attending an aged care facility to provide mental health services can claim the flag fall for the first resident. So if you're seeing multiple residents, obviously you can only claim it for the first, just like you can in GP land with just normal visits. And it can either be face-to-face at the aged care facility or at your consulting rooms if the resident is able to travel, and telehealth, and of course it can be done by telehealth as well, which has been extended to the 31st of December 2021. So that's great news as well. I guess the issue with telehealth is the ability of the elderly to actually access it. So that sometimes has a bit of a point to play. So it does require the development of a mental health plan by either patients or residents, regular GP or a psychiatrist. So a psychiatrist can produce the mental health plan referral. The initial referral must state the number of sessions. Every day I get phone calls from psychologists asking me, your GPs have sent a referral, but they haven't actually limited or requested the number of services. You can only refer for 6 on the first referral. So please keep that in mind. Even though there's 20 available, you can only refer for a maximum of 6 on the initial referral. And your referral, as I said, can be to your clinical psychologist, allied health and allied health mental health workers, so your OTs, social workers, or your trained GPs. Before the next set of services can be referred for, you must conduct a review. So after the first 6 services, a review is conducted, and you must have received feedback. So the feedback from the psychologist normally comes in to remind us, hey, we've performed those 6 services. We'd now like to continue on. Could you please review your patient and refer us for an additional 4? So again, the way the Better Access program works, you can now refer for 4 additional services. So that brings us to a total of 10. With an additional review of the mental health plan if it's been more than 3 months since the last review. So as you know, mental health plans can only be reviewed twice in a 12-month period, and they should be at least 3 months apart. After which you can now refer for the final additional 10 services if appropriate. So if you have your residents getting good outcomes from this program, then by all means keep referring them on for the additional 10. And it's surprising if you're seeing a resident a couple of times a week or once a week for 20 weeks is only 6 months and they've already used all their services. So it is a great program. I'm really pleased to see it's been brought out. Obviously, if a review is not claimable because the consult time or the review time is more than or less than 3 months, you can, of course, claim a mental health consultation for your resident. The referral requirements, this is the information that must be on a referral for mental health plan to a psychologist. Name, date of birth and address, obviously. the diagnosis, list of current medications, and of course the number of sessions being referred. So I apologise for the wordiness of these slides, but I am going to provide these to Bertha for you to access. So I thought the more information I can include, the more you'll be able to recall the information that I've given you tonight. And referrals can be across multiple years. So if you start or produce a referral tomorrow, and we're now in November, and the resident is not likely to access the 20 services between now and the end of the year, the referral can go through into the next year without having to do a new one, but it's only 20 per year. So it's very similar to the EPC program, maximum 20 services per year. So if you referred for 20 now and they use 10, they have got 10 available for next year, plus an additional 10. So it's still only 20 in total for the year. The other requirements, of course, is that the service providers must be registered with me. The service provision must be face-to-face or telehealth or telephone, but it must satisfy privacy laws. So when you're conducting either telephone or telehealth consults, you must ensure that the privacy of your residents is protected. There is also no requirement to bulk bill these services. So it's not mandated, where a lot of the COVID-19 stuff was, or the item numbers were, yes, you must bulk bill. This is not mandated to be bulk billed, so you are able to charge for your time, particularly if you're an allied health provider like a psychologist or OT, who, it's very hard to attract their services to aged care facilities for the minimal money that you receive. So being able to actually privately charge for these services is fantastic. So it hopefully will not be that barrier to getting these service provisions coming into the aged care facility. However, if you are choosing to charge the residents, they must be given informed financial consent. So they must be consented about the costs involved in the program before you commence it. So mental health item numbers, what is available? So there's a plethora of item numbers, so I'll try to make it as simple as possible. First of all, we're going to look at the item numbers for GPs to prepare the mental health plan. So as you can see, we're looking at GPs with both training and without training, so skills trained versus non-skills trained. And then we're looking at the time period. Obviously, there are other item numbers for the OMPs, but I've just focused on GPs for tonight. So they do mirror the rebates available for current mental health plans, but you must be using the item numbers that you can see in front of you. So if you're seeing a resident face-to-face for a mental health plan that's taking between 20 or greater than 40 minutes, then you would bill the 93403, which is the fourth line down, with a rebate of $139.55. And then, of course, you have your video and phone consultations as well, which all attract the same item number. However, you cannot charge the flagfall fee if you are not face-to-face. So if you're doing a mental health plan for a resident over the phone or via telehealth, you cannot claim the flagfall fee. So I hope that makes sense. It's fairly straightforward, and you are, as I said, will be given copies of these, so you'll be able to use them as a reference. The focused psychological studies that GPs perform, this is the GP item numbers. So there again are the item numbers relevant to each modality. So face-to-face, video or phone, and then the corresponding rebates. And again, it's broken down into time-based. So 30 to 40, 40 plus for the initial consultations, and then 30 to 40 and 40 plus for the subsequent. Then we have clinical psychologists, again, very similar to the way they charge or their fee structure now, all based on time, and again, face-to-face, video or phone with the appropriate rebates. And then you have your registered psychologists who obviously have less rebate, unfortunately, but there's also the flagfall fee down the bottom, which shows you that yes, for face-to-face, by all means you can claim, but if you're not doing a face-to-face, then the flagfall fee is not claimable. Then you have the OTs. I'm going to touch a little bit more on OTs because I think OT is probably one of the most underserviced providers in mental health. So again, focused psychological strategies performed by OTs. There are the relevant item numbers, and again, all based on time. And then you have your social workers as well, who attract the same rebate as the OTs. So I know it's a bit of a rush through because I am mindful of time, but it's quite clear where by looking at the form of modality, the modality of service plus the time gives you the item number that you need to charge. So just a brief overview of the flagfall fee for those who are not aware of it. GPs have an item number 90001, which has been around for well over 12 months now, so I'm sure you're well aware of it. and now the Allied Health have their own 9003, which allows them to claim a favourable fee, as I said previously, when they attend an aged care facility. So the requirements for the providers to meet the MBS eligibility, all providers providing services for the mental health component must be registered with Medicare. The resident must have a mental health plan in place and have used any previous sessions prior to being referred for the additional 10. So the first 6, then 4 must be used before you're able to generate a referral for the additional 10. And the resident must be not admitted to hospital. So they must be in the aged care facility and not be admitted to hospital for extended periods of time. So it's fairly straightforward, not too difficult to understand. Now, as I said before, I just wanted to briefly touch on OTs because since I've been doing these presentations, I've learned the value of them, and they're just so underutilised when it comes to the aged care component. So OTs assist adults who are experiencing psychological and emotional difficulties. In fact, I believe OT initially started with mental health and has moved into a different broader horizons. Obviously, the OT must have mental health training, but they can help people develop better ways to deal with mental illness in the context of day-to-day activities. So managing managing emotional problems. So they can help them to adapt their environment, and they can identify the triggers for their behaviour. So please consider OTs when you're looking at a referral process for someone that you may be looking after who you don't believe necessarily need psychological services, but may need more behavioural modifying services. And of course, they work in conjunction with GPs and other health professionals to get the best outcomes for the residents. And let's not forget the benefits of Allied Health for residents with dementia. Not only do they provide emotional and psychological support, but they enable engagement in activities and relationships with consideration of those people's culture and interests. So they look at what the culture is very specific, and they look at how they engage people who are culturally diverse, but also looking at what their interests are. What would they like to do in trying to engage them that way? So, and of course, finding suitable mental stimulation through either musical therapies, other types of therapies, or just through environment adaptation. So please, as I said, don't forget about OTs. They're fantastic. Allied Health play a huge part in this program. And I think if we can look outside the square and not necessarily think about just the mental health component, we might actually get some services provided to these residents that really can help them. I do want to touch on the DVA treatment cycle, which a lot of GPs are still not aware of. It's been around for 2 years now, and this does include mental health. And this is the reason I've included it again in tonight's presentation, because it does include mental health providers. So OTs, psychologists can also access this cycle. What it is a cycle of care that is continual. So one treatment cycle that is referred by a GP to an Allied Health provider is either for 12 visits or 12 months, whichever comes first. But that resident or that person who's the gold card holder, can also have multiple treatment cycles. So they can have as many as they want, and they can have as many providers at the one time as they want. So they could be having treatment cycles for physio, exercise physiology, psychology, OT. If those are relevant, then the more the better, I say. So don't forget about this program. I have put a link to this. If you're not aware of it, I'm happy to answer questions at the end of tonight's presentation. But it's available to gold card holders only at the moment, both high and low care in aged care facilities as well. So if you have a resident who isn't a gold card holder, please don't forget about this service, because it can complement, instead of using the Medicare component or the Medicare funded program, you can use the DVR cycle. And as I said before, there can be multiple cycles all working together. And if you use 12 cycles, so you send your resident for one treatment cycle of 12, and the OT comes back and says, I'd really like to continue my work with this resident, you can refer them for another 12 visits. So it's never ending, basically. The only, of course, there's always paperwork. So after the initial consultation, the Allied Health provider must create a patient care plan and identify the goals of the treatment. And they must also complete an end of cycle report at the end of each 12 cycle visits. And as I said before, aged care residents are eligible, but the mental health OTs are probably the one the most relevant if we're looking at tonight, the purpose of tonight's presentation. And of course, psychology, both general and clinical, and then not to forget our social workers. What's also been fantastic, which is probably not really related to tonight's presentation, but I just wanted to pop it in anyway, is that finally we have case conferencing for allied health professionals. So as of the 1st of November 2021, there have been the addition of 3 item numbers available for allied health to participate in case conferencing. So yes, allied health have continually participated previously at their own expense to talk to the GPs and other providers to get a plan of action for their residents. So now they're actually going to be finally rewarded for that. The residents must be managed under multidisciplinary care plans, and they must be instigated by the GP. So the case conference must be at the GP's instigation. However, it can be as a result of feedback from an allied health professional. So a physio, for example, or an OT could suggest that perhaps we could get together to have a chat about this resident, and then the GP could actually initiate it. There is no existing relationship rule, which is very limiting to, as we all know. So because if you have not seen, so if we look at, for example, physio again, physio, a GP, the aged care facility, and an exercise physiologist could be having a case conference. There is no need to know the resident because the conference is about how you're going to plan the care of this resident. So there is no existing relationship rule, which is fantastic, and they can be conducted every 3 months, exactly the same as normal case conferencing rules in general practice land. And of course, not to forget, there must be 2 additional providers, and those 2 additional providers cannot be family or carers. They must be other health providers. And of course, they can be by telephone or by video. So basically, these are the item numbers that are available. And again, it's exactly the same as normal general practice case conferencing. There are 3 levels of time. So 15 minutes to 15 but less than 20, 20 but less than 40, and then 40 plus. So I don't actually have the rebates. I'm sorry, I haven't been able to find them. So they're very tricky to get. So I will get them for you, and I'll get them through to Bertha, but they're not as well funded as the GP ones, unfortunately, for the allied health. But they are there and available to be used. So please remember those GPs. If you've got residents that you're looking after and you think that they would benefit from some case conferencing with their other providers now that they can, let's get it going. So speaking of GPs, what is your role in all this? Now we know what we've got available and how we refer. What are you going to do about it? What is your role in all of this? So the GPs obviously play a critical role in identifying mental health issues and referring for appropriate services. A medical diagnosis of mental health or mental illness by a GP or psychiatrist is important to ensure that the symptoms of cognitive decline or dementia are not mistaken for mental illness. So sometimes there's a misinterpretation of the symptoms, and they are, either put down as old age or just, a decline in their cognition, and they're missing the real diagnosis there. So GPs are vital in actually assessing and diagnosing these residents, or referring to geriatricians or other providers who can assess and diagnose. But they also ensure medication needs are met. So when you're looking at, mental health conditions, medication plays a big part in that. And it's important that GPs are monitoring those medications to ensure that there's not that polypharmacy, or that the residents are not taking inappropriate medication for their condition. Obviously, the incentives to care provision. What incentivises GPs to attend aged care facilities in the first place? I asked all my GPs that one question, and they said the most important thing for them was the reward that they experienced, because often GPs have been caring for these residents way before they went into residential aged care. They could have been looking after these residents for long periods of time when they were younger, through children and, losing partners. So the relationship between a GP and a resident that has a long-term one is very special. It allows GPs to initiate appropriate service for your residents to optimise their quality of life. You are in an ideal, optimal position to actually make a difference to your residents. And of course, there have been an increased incentives as far as the flagpole fee and other incentives. But the Aged Care Access Initiative is probably the most significant for anyone who attends aged care now. So previously it was capped at $5,000. Now it's doubled to $10,000. and it's based on a 4-tier system. So as you can see, 60 to 99 services generates the first payment of $2,000. And then there's very short increments from then on. So 100 to 139 is another 2,500. And then we jump up to about from 140 to 79, an additional 2.5 with a final payment of $3,000 once you hit the 180 services. Now keep in mind, it is services, not visits. So you could visit the aged care facility to see one resident but bill 4 services. So if you're smart about your billing opportunities when it comes to seeing your residents, those services will certainly stack up there. And it's an additional $10,000 to incentivize GPs to go into the aged care facilities and to see their residents more routinely. So GPs, what can we do? We can recommence or continue our regular reviews of residents. Since COVID, or since the impacts of COVID, it has changed the way we do things. A lot of visits to the aged care facility were more reactive versus proactive during the lockdown times. You weren't able to go at all. So it's about re-establishing those regular reviews of your residents. Adding reminders into your clinical software when you conduct your mental health plans to ensure that you don't forget to do the reviews or follow up on anything that you need. So it's very important that these reminders are put into your everyday facilities, to your GP land computer, so that the reminders are actually generated for you to say, hey, I've got to go back to the aged care facility and review my care plans for my residents or review their mental health plans. So that's very important that you add those. And it's also important that you engage with other providers to provide that optimum care. So whether it be psychologists or OTs or allied health professionals, physical therapies, it's about engaging and organising those case conferences so that we can provide that service to those beautiful people that live in aged care. And of course, scheduling regular visits in advance to ensure that you get adequate time. GP land is crazy at the moment, and being able to spend a couple of hours at the aged care facility just doesn't happen. However, if you incorporate that into your schedule in advance, you're more likely to be able to attend and spend that time with the residents that they really, really do get a lot out of. So that's GPs. Obviously, there's more than one player in this game. The other, of course, is the aged care facilities. What can they do to enable this program, get this working? Of course, general practice can't do it on their own. We're not able to do it on our own. We need to work with the facilities and the allied health providers to get this. So collaborative care is essential. Establishing relationships with visiting GPs and mental health practitioners is important for aged care facilities to enable the attraction of those provisions. So it enables you to build a rapport with those providers so that there's a more harmonious relationship. And of course, making the information available to the GPs when they attend. So care plans for review and any pathology or imaging that's been ordered by someone else that the GP is not aware of. And of course, the most important thing is any discharge on risk from hospital admissions, which the GPs don't often get. They often get sent home with a resident and we don't see them. So it's been really good to have all those things available. The other important thing I think is that having the staff available to attend when the GP visits to ensure that the GPs get a handover for what's been going on with the resident, particularly in relationship to behaviour and moods. And of course, the other most important thing is if we're going to have telehealth, we need to have staff who are trained to use it. So if your facility decides to go down the telehealth model, or the GP would like to do a telehealth consultation, or the mental health provider with the resident, having someone who's actually trained to assist the resident to actually conduct that would be really awesome as well. Obviously, recruiting service providers is going to be the biggest challenge. I'm sure you're all thinking the same thing I am. There's great services available, but how do we attract those providers to the aged care facilities? Either by contracting them, employing them, or just retaining what you have currently is I guess, the way to start. But also involving the family in the care, involving the family in the decisions that are made for their letting them contribute to what's going to happen to their mum or their dad or their sister is very important. And of course, always those regular meetings with your GPs or other providers. We have monthly meetings with our aged care facilities where we either go there or the facility, the manager and one of the nurses comes to our practice, and we sit and have a chat about what's going on and what's happening and is there any issues, and we work together to resolve them. I think that's really has changed the model that, or the level of care that we can provide, because we have the input into it. And of course, not forgetting the most important people are the allied health providers when we're looking at this component. So allied health professionals play an integral part of the team. This is based around allied health professionals, whether it be mental health or physical therapies. This program is about what they can do to restore the functionality of our residents. They provide a diverse range of interventions, and they can prevent or slow progression of some conditions. But most importantly, they empower the older people to live full and active lives. So allied health, what can you do? How can you assist? So accessing, contributing to care plans is a great start if you're allowed to. It should be that the care plans are available to be reviewed and actually you have some input in it. Again, the scheduling of routine visits to allow the therapies to continue or to commence and continue. Having regular discussions with the aged care facilities about what you'd like to implement with them and to work together to achieve best outcomes for both yourself, to ensure that your business thrives, but also the best outcomes for the patients. And assist the aged care facility in care plan creation and documentation so that the service or the aged care facility knows what you would like them to do while you're not there. And that can include exercise, diet, as well as therapies. So as I said before, exercise is very important, and so is a good diet and therapy for mental health. So we shouldn't forget about these when we're looking at the big picture. So these are the links I've provided, which gives you each specific area. The allied health one is from the first presentation that I did, just if you wanted to have a refresher on that, but the other two are based around tonight's presentation. And before I complete the last slide, there is just two things I'd like to talk about. So I didn't include in the presentation, I apologise for that because I was focusing on the mental health, but I just want to briefly talk about the couple of new initiatives from the 1st of November in GP land. So obviously in GP land, there's been the case commenting, which is fantastic, but from the 1st of November, there's also the ambulatory blood pressure monitoring. So you are now able to claim $94, I believe, to conduct ambulatory blood pressure monitoring, or the resident can claim $94. So that's a real great incentive. So I hope you're all aware of that. The other thing that was introduced was the consultation available to GPs to conduct for people, their patients who have had contracted COVID-19. So it's not a great amount. I think it's $25, and it must be co-billed, so you cannot bill on its own. It's very similar to the 18660. You have to bill it with a 23 or 2713. But please be aware that they are out there. So it's purely just information, but I do like to share what I know. So if you'd like more information on that, I'm happy to provide that to you again after the presentation. So to complete my presentation, ladies and gentlemen, in a nutshell, the effects of COVID-19 has been absolutely devastating to our elderly Australians living in aged care facilities. And only by the provision of a collaborative, person-focused model of care can we address these issues to ensure that our residents get the services that they need to improve their mental health, which will therefore improve the quality of life for so many of these people. So please get involved with this program. Please make your referrals. As I said, happy to answer any questions. I'm now going to hand it back to Evelina, who can continue on with the presentation. So thank you very much.
So I'm just going to quickly talk about the mental health programs that PHN has commissioned. I'm going to briefly talk about 3 programs that we have, and I believe would be a really nice segue from what Wendy has presented, and she has very nicely covered the issues that RACFs and the older people with mental health are facing. So the first program that I'm going to talk about is the emotional wellbeing program that we've commissioned with Anglicare. It's basically a program that's commissioned for residents in the residential aged care facilities. The aim is to provide mental health services, mainly the psychological and psychosocial therapies to the residents in the facilities. And then the main criteria for anybody to refer a resident from this program is to have an MOU with Anglicare. This is mainly to promote the collaboration and then involve RACFs into the care of the resident. Anybody who is actually working at the residential aged care facility or a GP who is involved in the care of a resident, psychiatrist, RN, or an allied healthcare staff can make a referral. When you're making a referral, we ask that you provide us with past or CAMS assessment, mainly to confirm or actually to make sure the person that you're referring is cognitively aware, to understand and then work with the provider and the workers in the program. And also, as Wendy mentioned, consent is also crucially important when you're referring to the program. For more detailed information on the program, I'm just putting the details for Anglican, how you can contact them. And if you would like further detail about the program, I'll put my details towards the end and you can contact me. The second program that I want to talk to you about is the Reconnect Wellbeing Program. This program is actually for residents living in the community. This was commissioned after the COVID-19. So basically with this program, anybody who's actually feeling isolated because of the COVID and the circumstances that it has resulted in. So if you know anybody who's living in isolation and is feeling difficult to deal with this situation, especially after the lockdown or during the lockdown, whatever that happened. And then all you have to do is just call this number, or you can actually send an email to this email address, and then just mention that you would like to refer this person, and then the team would get in touch with you. And then they will talk further to the person that you're referring, and they will help and provide and link them to the services that they're looking for, any kind of care. This program is actually available face-to-face, and they do provide online or phone services. They do offer culturally and linguistic support for people who cannot speak in English. And if you'd like to make a referral, this is fairly just call and then they would get in touch. The last program that I really want to talk to you about is the Head to Health pop-up clinics. They were commissioned during the lockdown. So basically this is actually available for anybody from not to 65 above, everybody who's facing difficulty during the pandemic. So all you have to do is just call this number, and the two centers, the two pop-up clinics are actually available in Hurstville and in Lakemba. The idea is to support people dealing with mental health issues, mild, moderate, or severely intensive. So basically, they'll talk to you about your goals. They'll help you link to the service, help you with self-management strategies, or anything to do with reducing your stress. So if you have any other question related to these programs, happy for you to contact me.
Great areas. So
I'm very happy, Evelina. If anyone, my email is on the presentation. If anyone would like to touch base directly with me to ask any questions or to get more information, I'm very happy for that to happen. If even I want to touch base with Bertha and she can provide the information, my contact details, and I do it all the time, and quite often have built up quite a few relationships with people since these presentations just for answering questions. So I'm very happy to do that if anyone would like to contact me directly.
perfect. I can't see any more questions, so I think we can wrap up for today. Thank you very much, Wendy and Riva. Thank you, our audience, for spending time with us tonight.